Very real, very true. We've seen a lot of projects come and go, but we've also seen some projects staying on. And for me, that's actually one of the priorities of what we do and how we do it, and why itDU-it is very critical.
Hi everyone, welcome to the itDU-it podcast series. It means to see linked data, and do it means act on the data.
Let's make every contact count.
Core concepts in quality improvement.
Doing things differently.
Mentoring, support, supervision, and coaching.
Client perspective.
Data quality, digitization.
We are itDU-it. Welcome to the itDU-it podcast series. My name is Vicky Doyle. I'm the Quality Improvement Advisor to the itDU-it programme. And today we're going to be talking about what is itDU-it. So I'm delighted to invite to the studio Dr. Lilian Otiso. Can you just introduce yourself a little bit, please?
Thanks, Vicky. My name is Dr. Lilian Otiso, the Executive Director of Lvcthealth and the co-lead of the itDU-it project, which we're doing right now in Homa Bay, with my counterparts from Cambridge and Liverpool School of Tropical Medicine.
Okay, fantastic. So here we have some of the brains behind this whole program, and really delighted that you're going to be sharing your thinking, your knowledge, your wisdom with us all today. So as normal, I like to start with a provocation, and today's provocation is: projects come and go, lessons learned are often forgotten, leaving little lasting legacy. So we're going to ask a few questions now, and hopefully you can respond to some of that as we go along. But maybe to start with, just can you tell us a little bit more about what is the itDU-it program? You know, what is it? What does it aim to achieve? And what makes it unique?
All right, thanks, Vicky. And in terms of your provocation, very real, very true. We've seen a lot of projects come and go, but we've also seen some projects staying on. And for me, that's actually one of the priorities of what we do and how we do it, and why itDU-it is very critical. So itDU-it itself refers to a project which we started aiming at working with community health workers to see the data they have and make sure it's good data, to make sure that they have access to good data, and then they can use it in terms of do it or data use. They can use it to improve the quality of services that they're providing at the facility level. And for those who may not understand how the structure works, is that we have the health system with health workers in the health facilities at different levels. So we have the lower level primary healthcare facilities, and then you move on to higher levels and the hospital. So the community unit is the level one, and it's composed of community health workers and community health assistants who are their supervisors, and all of them report to the sub-county and county structure of community health. And so the role of community health workers is to do a lot of health promotion, health prevention, educating the community, identifying household members, and making sure they provide them services and link them to the health system. And the gap for us was that how do you make sure that what they are doing at the community level is of good quality? And secondly, that whatever happens in the community, there is a referral, a functional and optimal referral to the facility, and they communicate with each other. Because what we found, and this has come from many years of doing these projects, actually we've been implementing community quality improvement projects in Kenya for about 15 years now, from what we call reach out and scale. And so in terms of legacy, this is one of those projects which has built onto another, and we've kept on learning and iterating the versions. And so the goal of itDU-it is we bring community health workers, their supervisors, and the facility staff together. They look at the data they have, because we have data collected at community level. And these days, fortunately, in Kenya, it's electronic in something we call the Electronic Community Health Information System, or ICHIS for short. And then we have data at the facility level. But they don't speak to each other. And so the idea for us is, how do we bring in community health workers, their supervisors, the facility staff? They look at their data together, find out, make sure it's good quality data, and then have quality improvement cycles to address specific needs that they have. And for itDU-it project, we started with the antenatal care, because that's a priority in the country. We have very few women actually completing 4 ANC visits, which is what is expected, which was what was expected. In fact, now it has moved to 8 ANC visits. And there's no way that women will go to the facility without some demand generation, some information, education. And so by bringing these teams together, they've been able to look at their data and find out why the women are not going to the facility and come up with solutions. They're within their own resources, mobilize the women, and now we are monitoring to see, is it actually improving the visits? And it's a research study, which is also an implementation study. So it's implementation science accompanied by a trial to ensure that the outcomes we monitor and we track, did they actually happen based on what was said? So very exciting for us in terms of legacy projects that are actually responding to the current needs of the country, and we hope to see good results sustained.
Yeah, so very significant work and really trying to strengthen the interface where the community interfaces with primary care, which, as we said, that gap has been there for a long time. You talked about antenatal care. Can See It, Do It work in other thematic areas as well?
Yeah, absolutely. So in the country, the community health program, the community health workers are tasked with going to households. They register everybody in the household and say, in this household we have a man, a woman, a adolescent child, a child, and then monitoring them for all their diseases. And so we just started with antenatal care because of priority and related to the priority of maternal health, but it can work for anything that is monitored at community level. So even going beyond ANC to the broader maternal mortality, for example, one of the things we're intending to do is actually track maternal deaths and do maternal audits for at the community level using this approach. It can also be used for TB, HIV, malaria, whatever it is that requires a quality improvement approach. And everything is really amenable to quality improvement approach. And we've simply simplified it. That's all we've done. We took out all the jargon and all the hard words that we medics love to use and made it so simple that a community health worker with a basic education level can understand that this is the data, that this is what the problem is, and why do we have this problem, and what can we do about it, and then do it collectively.
Absolutely. So keeping it simple, jargon free, and as we said, doing something with that data, acting on it to improve health outcomes. So maybe another question now, thinking about some of the policy implications, because that lasting legacy is really important as well. There's been a lot of policy change in the last few years since the See It, Do It programme has been running. We've seen the massive digitisation. We've seen CHVs change to community health promoters. We've seen the Primary Healthcare Act, primary care networks, also changes to the social health insurance. So a lot's been going on. How have you managed to make sure that See It, Do It aligns with national policy? And conversely, what can See It, Do It to contribute to? How can it influence national policy, but also practice?
Thank you. Now that you're even describing it that way, just shows how there was so much change during this project. And it was one of the most difficult, but also exciting parts of it. Right from the design of this project, we were very clear that we are not coming in with a parallel program. And unlike what most people say about NGOs, that you're working in silos and in a parallel approach, we've been a core part of the Community Health Technical Working Group. We've been part of those policies that were being developed for community health, and we've always engaged with national policy and even county level policy in country. And we were very deliberate that whatever it is we do has to align with the national priorities. A funny story is that when we were writing the proposal, we even had meetings with the government, and the priority was how can we align and address the digital chaos, because there were so many digital tools that community health workers had to use. And the first question we said is, how do we come up with a criteria that government can use to pick one system that works? And then that's a system we would use to test, can the community actually have good data? Fortunately, along the way, the government went round, selected, and came up with itDU-it, and that was rolled out as we were implementing. And our value, the value we bring in is to operationalize itches. As part of the project, we trained the health workers, the community health workers, to use itches, and then now we went a notch higher, and we've worked on integrating itches with the community, the facility level data. Currently, where we are in Homa Bay, they're using Kenya EMR, and we're very glad that the government has endorsed digital tools for facility level data or the electronic medical records. But there was that gap in between. How do you connect the two? And so the innovations we bring in are really about bridging those gaps from policy. So policy has been developed, we facilitate its implementation and also keep identifying those gaps. And how do we respond to policy then? We exactly that way. First, it's informing, are there any helping the policy to be rolled out, and then identifying any gaps and feeding back to the government, whether at national or county, to address those gaps. And then the third thing is, based on the findings we have on the ground, we can inform other policies or other tools and guidelines to be developed. One key one that we've done, and that started with the project scale, was there was very good Kenya quality model for health, which was QI at facility level. And there was a huge gap in terms of, can there be quality improvement at facility level? And we developed that through the SCALE project, working very closely with the Ministry of Health. And that then informed the Kenya Quality Model for Community Health, or KQMCH.
Fantastic, yes.
So that's an example where we've actually translated our research, we've identified a policy gap, we've implemented it and tested it in research, and have informed national policy.
Yeah.
And right now that is being rolled out as an electronic format, the EKQMCH, and we're very much a part of that, aiming at really just keeping on strengthening the policy and practice for community health programs.
And I think that is such an important role to play, because we see time and time again paper policies, but then they never make it into practice. And I think what I'm loving here, you're also talking about how practice is informing policy. And that I think is really important as well. That's a bottom-up approach to strengthening policy.
Actually, yeah. And for Lvcthealth, we're very clear that our approach is about using the end-to-end research policy practice cycle approach to address the needs of vulnerable and marginalized. And so always innovating. We see ourselves as an innovation hub for not necessarily those very shiny innovations, but more about service delivery innovations that make things work for the
Making
communities
things
we
work
serve.
on the ground.
Yes.
And actually, you just started talking about so reaching marginalised or vulnerable groups. How, within the See It Do It program, how have you tried to reach out to those more vulnerable groups?
Yeah. So we as an organization have always done that, and we know, and wherever we go, we know that government will always roll out interventions that reach the masses and the public, but within that there are those who will be left behind, and unless someone pays attention, they will not be captured or remembered. And most of it's a gap around data or involving them in co-creating solutions and co-designing the interventions. For See It Do It in particular, we identified adolescents because our focus was on antenatal care, which is related to maternal health. We do have a serious problem of teenage pregnancy in the country. We have over 15% teenage pregnancy rate in the country. And so it was clear that we cannot do an intervention on maternal health and ANC without looking at adolescents. And we deliberately set out to include adolescents within the work improvement teams and have a question addressing the needs of adolescents. But also we brought in a unique aspect where we created what we call an adolescent work improvement team, which was composed of adolescents drawn from the different units we had to come together and drill down to what are the problems. So they always have to start with the statement of the problem. What is the problem? There's high rates of teenage pregnancy. Okay, that's a very big problem. What is it that you can actually address? And something about they're not accessing antenatal care. And so doing a root cause analysis of why, and really driven by the adolescents themselves, partnered with the county teams so that the solutions they come up with are also practical and they already feed into the system. And they were very exciting. I mean, they came up with some fantastic...
And they speak to youth, don't they?
Yeah, they do.
Adolescents, because they're coming up with their own solutions.
Yeah, and they are very passionate when presenting what they did and what they found. And we see this going very far to actually ensure that even as counties implementing these interventions, whatever type of interventions, they have this work improvement team as a trained pool of young people who can inform their
So it's
priorities.
giving that voice to, in this case,
Yes.
young people.
Exactly. And
Yeah.
agency, so that they can
Yeah.
have a choice and they know what to do and they can have power to do something and improve teenage pregnancy. So we hope that this will also help to contribute to that national priority. Yeah.
Okay, and maybe just my last question to you, Lillian. The program has really been about strengthening health systems, but starting right at the community level. Just reflecting on the program, what do you think have been? You've mentioned some innovations. Are there any other innovations you'd like to talk about? And what do you think has been or will be the lasting legacy of this program?
Yeah,
It's a small
thanks.
question.
Yeah. And so with this program that brought in a range of people and very strongly brought in the community itself, it's been interesting the kind of innovations we've come up with, very simple but useful. The first one that was the idea that we had, and I think I mentioned this, was what we're calling the linkage module that links each is or the community data and the facility data. It seems like a no-brainer that really you need to have data that's speaking to the community data speaking to the facility data. And what I mean by this is that when you do a referral, when a community health worker refers to the hospital, it needs to be seen, and that's what we came up with. So it's very simple, but right now it empowered the community members a lot because their frustration was their referrals are never completed, and they don't know what happens when the women they refer go to the facility. So now we have the bidirectional referral. When a woman is referred, the health worker sees the referral and the reason. And when they see the woman in the ANC clinic and they update their electronic medical record, it's seen back at the facility, at the community level. So they're able to tick and complete and they're satisfied. It actually motivates them
Of
a
course,
lot.
yeah.
The other one that started actually as a study tool and then now has become a sensation for us. We're calling it the silent supervisor. It was a community case report form. And that's why I said it was a case report form, because it was a study tool. Because our question was, what happens when a community health worker sees a woman when he or she visits a woman in the household? Where is that data recorded? There's data already recorded in the electronic handheld, the smartphone data for the itches, but that is only for the community health worker reporting that they worked. And actually, the reality is they don't even see that data once it goes. But how are you going to be able to see that when they visited this woman, they provided quality services? And so we came up with a very simple tool, that the CRF, which we're now calling the chart tool.
Chart, yes.
Yeah. And the chart is a way of community health providers charting what they saw. And so they'll visit the woman, they'll note things like the date, they measure the blood pressure, what they found, if they made a referral, if they gave some of the basic medication like the supplements that the women get, or dewormers, for example. If they gave that, then they'll report it. And it's attached in the mother-child booklet, so it's not separate. And that's why it's not electronic, because it accompanies the mother-child booklet. And once that is done, when this woman goes to the hospital to see the nurse there, she's actually able to verify that, okay,
So
my patient has actually received the treatment she needs, her blood pressure was normal, and now she can check again. And so it does that part of completing the referral also, but also tracking and ensuring that the community health worker is doing the right thing when they visit the household. And it's been quite exciting for us. Interestingly, the community health workers really appreciate it, even if it might look like a supervisory tool, but they feel empowered that their work actually counts when it sits in a woman's.
Oh, before it was
antenatal room.
invisible, wasn't it, I suppose?
It was completely invisible. Yeah. And so for us, that's a very exciting approach. And the other innovation is actually just the whole do-it model, or what we're calling the work improvement teams, which bring together the community and the facility. It's so simple that you cannot solve health problems only by talking to health workers.
Yeah.
Yet these women are coming from the community. And then you cannot solve all the problems by talking to the community health workers in silos. In health, we love silos. Everybody's doing their own thing in their own way. But bringing them together to discuss and look at their data and come up with solutions based on their realities on the ground. We've seen fantastic innovations, like male engaged. Then when they discovered that the adolescents or the women are not coming because their male partners are not coming, and the facility came up with an innovation for bringing the male partners, encouraging them to come in, and it actually made the numbers of ANC, fast ANC or later ANC really improve. For us, that's exciting.
Yeah.
And the final one I'd like to highlight is the community pregnancy testing. Again, sounds like, okay, not such a big innovation, but the truth is, one of the gaps we suffer from is that when you want women to take up antenatal care visits, you want them to take up 8, they cannot start visiting at 7 months or at 6 months. The earlier they do it, the better. And we found that when a community health worker goes to the household, and one of the questions they ask is when was your last menstrual period for women? And then they find that seems like she could be pregnant. Previously, they would suggest that maybe she's pregnant, refer for a pregnancy test. But we empowered them. We gave them kits, these kits that are sold in pharmacies that people do as self-test kits for pregnancy. And they were able to administer those in homes. And we've seen a very good uptake of fast ANC visit because of that. And there is a paper we had published about that, because this is also building on a previous study. As I said, for us, it's always building on what works.
So we're not losing any of that learning.
Yeah. And so the community pregnancy test is another innovation that we're proud of.
So fantastic examples of innovations, which, as I think, as you said yourself, we often think of innovations as being high tech, state of the art, but often they can be very simple things, and I think we sometimes underestimate the power of doing things in this simple way, because they're more likely to be sustained as well. So, as I always like to do at the end of the podcast, is to ask our panelists, what are your key messages? And we're looking for 3 key messages you would like to give to our podcast listeners.
Yeah, thanks, Vicky. Not a hard task at all, of course. But anyway, I think there's been a lot of learning from this project. And for me, the 3 key messages are: communities know what needs to be done, and they just need the tools and support to do it. And that's what we've been prioritizing. The second bit is that when government prioritizes and invests in community strategy or in health innovations, then we see huge results. A lot of this work we've been doing, as I mentioned, for 15 years, but a lot of traction has come because government has prioritized community strategy and invested in it. And the third part that then relates to that is that you do need trusted partners who are very embedded in those communities. And of course, I'll speak about like the role that we play as Lvcthealth. Because of we are a local organization that is embedded within those communities, and we understand the needs there. We are able to translate ideas and policies into practice, and that are sustainable and that are practical, and the communities actually appreciate them. Thank you.
Thank you, Lillian, for joining the podcast today and
My
for
pleasure.
sharing your wisdom and knowledge. Thank you.
It was my pleasure. Thank you, Vicky.
Let us do